Hi, everyone. I'm Tuya Pal. Welcome to our January ICARE case conference. And I want to start by wishing everyone a very happy new year. Just as a side note, ICARE is we're in our 15th year. And again, you see some of the metrics there, but we again are very appreciative to all of our provider partners and our participants. I know we have a lot of content to cover. I want to start off with an ATM focused case of a participant that actually participated in this tumor genomics study, which I found kind of interesting. This is one that myself and my colleague, Dr. Sonia Reed, co-lead. So it's a 35-year-old who at age 27 had genetic testing. It was through BRCA plus, which was negative, and BRCA plus does not include ATM. It's the high penetrance breast cancer genes. Age 30, diagnosed with DCIS, treated with double mastectomy. Age 35, keep in mind, after a double mastectomy, diagnosed with stage 1 hormone receptor positive breast cancer in the contralateral breast that the DCIS was in, treated with surgery and radiation therapy, but then found subsequently to have a local recurrence post-surgery. The Oncotype score was very high. It was 39. And then you can see here the family history where mother had breast cancer at age 34, died at age 39. There is a grandmother with pancreatic cancer and an uncle with pancreatic cancer, and then the sister with melanoma. And so again, 2016 result was negative. The 2024 result, there was a pathogenic mutation in ATM that was identified. So what's interesting about this case, again, this was a stage 1 breast cancer, so typically there wouldn't be tumor sequencing, but this patient participated in our tumor genomics study through ICARE. And what was found here is that copy number gain of HER2 path report that we already had on file was HER2 negative. But this prompted subsequent FISH testing, which showed HER2 amplification. And my colleague, again, this wasn't a patient at Vanderbilt. However, my colleagues, Dr. Park, who's our cancer center director, as well as my colleague, Dr. Sonia Reed, kind of advised me, and then Dr. Park interfaced with the patient's permission with her oncologist. And again, that's how treatment was actually modified based on these results. So again, just a quick story to kind of highlight, sometimes research can be translated into patient care. I think Sonia is on the call. Sonia, if you want to chime in with anything, feel free. Mark, do you have any? Our guest expert today is our well-known Dr. Marc Tischkowitz, but Mark, do you have any comments here?
No, I think I mean it's interesting what you've got there. I mean, typically these are ER positive tumors, and yeah, I mean I think it's interesting how you managed to take this another step forward, essentially.
Yeah, and I have a comment from Sonia. This is a great example on how treatment can be modified. So yes, agree with that. So again, we're still recruiting for this study. So if you do have patients with mutations in those genes and breast cancer, please consider telling them about ICARE. Now, the focus of our case conference today, we have a lot of exciting cases to discuss, but we, after, I don't even know, maybe a year and a half of work, our ACMG sponsored ATM practice resource was released in early December. And this was an effort that myself, Mark, and Catherine Sean worked closely with many of our worldwide colleagues on. And again, you see here the multiple people from across the world that worked closely with us on this effort. So it's my pleasure to have Dr. Marc Tischkowitz, who all of you probably already know, who is the head of genetics, the Department of Genetics, I believe, at Cambridge, and very well-known clinical cancer geneticist who will be doing just an overview of ATM heterozygotes and our paper, and then we will go through a number of cases that are, again, super interesting. Marc, take it away.
Thank you very much, Tuya. And great to have the opportunity to present these guidelines that have only just come out. And I thought the first slide just shows really that this is, we've done this. This is the third set that we've done. We've been working our way through these genes that people have, previously been struggling a bit with. So we started with PALB2, then CHEK2, and now ATM. And it is a real testimony to this excellent international working group, actually, that we have lots of discussions, often at anti-social hours, that are actually very constructive. So I'd like to now, are you going to advance the slides for me? Yeah, thank you. So in terms of history, well, ATM's actually been known about for a very long time, originally identified as a gene in ataxia telangiectasia, and the breast cancer risks were, this was back in before even BRCA1 and BRCA2 were well established. And that original paper actually showed a twofold increased risk back in 1987. So it was an epidemiological based study, and those risks have held firm over the last 35 odd years. So the gene discovered in 95, and then the risk estimates always, were really firmly established in the mid 2000s. So we've known about this gene for a long time, but that doesn't mean to say that it isn't quite problematic, as we're going to find out over the course of this session. So in terms of risk estimates, the most recent ones are from the case control studies, the two case control studies, large ones that were published in the New England Journal a few years ago now. One was the British one was the more European one, and the carriers one was the US one. And you can see that there's good concordance there actually between the two in terms of overall risk estimates and penetrance. And that's been consistently the case throughout the history of study of this gene. So those are sort of the point estimates, but actually if you then look at the variation in the gene, it is quite pronounced. And this was quite a well-known figure where one superimposed the polygenic risk scores onto the point estimates, and you can see how there is overlap between all the genes here. And at ATM, the range of ATM goes back all the way to general population risk, up to a few cases that are sort of just on the boundary with the lower estimates of BRCA1 and BRCA2, with the majority being just over in sort of the more moderate range, as we call it, essentially. So that just gives you a good example. So these are the the risk estimates numerically. So twofold risk of breast cancer, around about a 6% risk by 50, and 32% risk by age 80. There have been studies looking at other risks. I think the most interesting one is the pancreatic cancer one, which does actually seem to be quite high. I think the confidence intervals around these are still quite large, but ATM is emerging as an important pancreatic cancer gene. So you can see those risks are pretty significantly high for this gene. Ovarian cancer is more tenuous, and if there is an increased risk, it seems to be below the sort of threshold of actionability. Also with prostate cancer, I think there are still some issues about the actual confidence intervals around the risk estimates. although there is evidence that it does, that ATM germline pathogenic variants do seem to be associated with aggressive disease. Limited evidence for male breast cancer. There probably is some risk, but given the lower penetrance of this gene, it's going to be even lower for male breast cancer, and therefore the signal will be quite hard to pick up. And also some, mixed results for gastric cancer, potentially some increased risk. Contrast breast cancer is really interesting because both carriers and bridges studies, so again, these are the case control studies, they both showed that all the well-known breast cancer genes that we know about do have an increased risk of contralateral breast cancer, with the exception of ATM, which doesn't seem to have an increased risk of contralateral breast cancer in either study. And this has been the interest. I think this has been generated quite a lot of interest and speculation why this may be. One possible explanation is that ATM breast cancers are typically ER positive. So one could speculate that if a woman has an ER positive breast cancer and is then having endocrine therapy, that endocrine therapy has a very strong preventative effect in the ATM compared to BRCA1, BRCA2, PALB2. So that could be an explanation. But then CHEK2 breast cancers are also ER positive, and you don't see the same effect there. So, whether that's the full explanation or whether there's something very specific about the way that ATM causes breast cancer that makes it particularly sensitive to endocrine therapy, or there's some other mechanism, or is this still small numbers and maybe there is an increased risk of contralateral breast cancer, but it hasn't been seen yet in these studies. So I think we don't really know at this point, but it's interesting that both of these studies showed, were concordant in this when we're looking at contralateral breast cancer. One of the things that's important to remember is that there does seem to be a higher risk with certain missense variants. So the well-known one is the 7271T2G, which is actually reasonably common. This was first described as a high-risk gene quite a few years ago, and there has been some consistency in this over time, except it wasn't seen in the Bridges study, the most recent study. But it probably is, and I think there will be more data on this in due course. So it does seem likely that there is a higher risk for this gene compared to the other types of ATM variants. And this is very much specifically to a particular domain at the 3' end of the ATM gene as well. So coming on to the recommendations that we made. So importantly, we felt that it's important to individualize risk in women who have ATM pathogenic variants and to use something like CAN-RISK, but be aware that CAN-RISK currently is not designed to incorporate risks that deviate from the typical truncating pathogenic variants. So you can't use CAN-RISK for the particularly high risk variants like the 72771. So that's always something important to wear. So for those high risk variants, you at the moment there isn't an easy way of modeling or individualizing risk estimates, and that's something that the CAN-RISK team are working on, but we're not there yet with it. The other key points are that most women who have an ATM pathogenic variant will meet criteria for some form of advanced surveillance, but not for risk reducing surgery, essentially. And also those who have a breast cancer diagnosis, typically their risk of contralateral breast cancer wouldn't be increased as I've just shown you with those two studies. So contralateral risk reducing mastectomy shouldn't really be routinely offered, particularly when endocrine therapy probably has quite a strong effect in these women. In terms of pancreatic cancer surveillance, this is something that there's quite a big difference of opinion internationally, and I think it's more accepted in the US to offer pancreatic cancer surveillance as part of routine clinical management. Certainly in the UK, this is not the current position, where we still feel that the evidence is insufficient, that it reduces mortality, that there is a mortality benefit, and we still run pancreatic surveillance as part of as a research study, not as standard of care. For prostate cancer, again, a bit of a difference of opinion about PSA screening. Note the word consider there. So we're not absolutely recommending it. This is something to, perhaps based on family history, for example. And I think that in the US, this starts a bit younger. In the UK, we would start out at 50. For ovarian cancer, there isn't evidence to support any preventative surgery. But clearly, if there's some family history, then that will influence management, particularly if there's some surgery planned. In terms of therapy, this was a study from a few years ago which showed that the ATM and CHEK2 genes are not, do not seem to have a response to PARP inhibitors, essentially. Whereas something like the PALB2 gene, pathogenic variants in breast cancer related to that does have a response to PARP, and I think that's quite important to remember. So ATM CHEK2 are working in a different pathway to PALB2, BRCA1, and BRCA2. And but interestingly, despite evidence of efficacy in patients with in this context, olaparib has been can be given as a monotherapy. I think this is again more of a US thing because it's FDA approved. So it can be given in the context of patients with metastatic castration-resistant prostate cancer. But I'd be rather skeptical about, based on the evidence that we have for breast cancer, I'd be rather skeptical about the utility of olaparib in this situation. And we don't have any evidence of clinical benefit for targeted therapies in other tumor types. So I think if you have a woman who has for breast cancer with an ATM pathogenic variant, they would just get standard of care. Typically, they are ER positive, so they would be going down that route. Another important consideration is that radiotherapy, as part of standard of care for breast cancer, should not be avoided. For many years, I mean, there's always been some issues about this because of the biallelic. When someone's got biallelic pathogenic variants in ATM, they have ataxia-telangiectasia, which is very radiosensitive. So there's always a concern about heterozygotes, and particularly in 20 years ago, there were some studies showing that heterozygote cell lines may be more sensitive to radiation treatment. But this hasn't been borne out in any clinical evidence, and therefore, women with breast cancer with ATM germline pathogenic variants should receive standard of care treatment for their breast cancer. In terms of partner testing, as I've just mentioned, there is this. If a child inherits a pathogenic variant from both parents, then they will develop something called ataxia-telangiectasia, which is quite a very sort of nasty childhood onset recessive disorder, particularly affecting neurological, immunological, and also with a high cancer incidence. And this should be something to be discussed with patients. And partner testing may be offered. Again, there are some differences about according to which country one is in regarding that. In terms of because ATM pathogenic variants are not particularly uncommon, it is, and certainly CHEK2 is not uncommon. You may see double heterozygotes with this, and certainly if ATM is combined with, say, BRCA1 or BRCA2, the penetrance for the more penetrant genes will outweigh whatever occurs with ATM. So I think these situations are quite special situations and worth looking at on a sort of case-by-case basis. And again, this is something that where CAN-RISK will particularly be helpful. These are the NCCN guidelines, which Tuya has led on, and gives you an idea of the lifetime risks and the management for this. So typically, mammograms would be reasonable for age 40, and again, this could be tailored, depending on the lifetime risk, using something like CAN-RISK. In terms of what we do in the UK, the main differences would be, I think in terms of surveillance, it's fairly similar. Again, we wouldn't offer risk-reducing mastectomy routinely, but if there's a particularly high risk, then it can be considered, so 30% and above. I've already mentioned that for pancreatic cancer, we're quite divergent compared to the US there, because we would not offer that as part of routine clinical care. And there's no formal surveillance program for prostate cancer. We would consider it PSA from 50. In terms of partner testing, this would only really be offered if there was consanguinity in the family. So to summarize the recommendations, so breast cancer surveillance recommendations should be based on individualized risk assessments. Most women will meet the criteria for enhanced breast surveillance, and there will be some differences based on country-specific guidelines. Key point is that CanRisk is not currently designed to incorporate risks of these higher risk missense variants, and that women typically do not usually meet the threshold for bilateral risk-reducing mastectomy. But it can, but if there's a particularly strong family history and the risk estimates are sufficiently high, then it's something that can be discussed. And the similar situation applies to contralateral risk-reducing mastectomy. And pancreatic cancer surveillance considered, but ideally part of a clinical trial. Consider prostate cancer screening. No evidence to support risk-reducing nephrectomy. So, and this is all sort of standard of care essentially. So ATM heterozygotes should be referred for a discussion about cancer risk, should be offered appropriate genetic counselling, also discuss reproductive options. And we're offered predictive testing should be done in the context of in terms of genetic counselling. And there's also this issue about we'll come back to this in the cases actually, but there is this issue of even women who have negative predictive tests, they may still be increased risk of breast cancer, sufficiently increased risk to offer additional surveillance. So again, this should be personalized using a tool like CanRisk. And genetic counselling should include biallelic inheritance. Finally, just in terms of where the areas of need. I mean, one of the things when we're doing these papers is we notice how many areas there are still uncertainties. And I think one area where ATM penetrance, will be really improved is by incorporating polygenic risk scores. It's clear that polygenic risk scores will have much bigger effect on the moderate risk genes like ATM and CHEK2 compared to the higher risk genes like BRCA1 and BRCA2. Because the polygenic risk score could really influence the ATM risk and can really change clinical management. We also need better prospective collected clinical data. There's this whole remaining issue about contralateral breast cancer risk, so that needs we need some better evidence about that and whether it really is related to treatment effect. There's limited data on therapies, and also the risk for other cancers still needs more data to really improve the accuracy of those estimates.